Hey, welcome. My name is Kathy, and this is our journal of learning about and living with lichen sclerosus, where I research or talk to someone about lichen sclerosus and bring you the information so you don't have to go searching. I bring you the real talk without the medical jargon. This week, we're going to be talking to Dr. Rubin, a urologist outside of DC who specializes in sexual medicine. We're talking to her about non-surgical ways of reversing clitoral fusing, which can be a major problem with LS. I'm super excited to bring you this conversation because it is going to be eye-opening for you, and you're probably going to want to be making an appointment with Dr. Rubin ASAP if you are dealing with clitoral fusion. If you enjoy the podcast and Lichen Sclerosus Support Network has been beneficial to you, think about becoming one of our recurring donors. As a benefit to our recurring donors, we have the Lichen Sclerosus Support Network membership. Part of that membership is a private community off of social media where we share evidence-based information with you and provide you with live interviews with specialists like Dr. Rubin, where you can ask questions and hear these episodes before they are released to the public. We also host live virtual sessions where we come together as a community. Another perk is you get discounts on our events, like the Holistic Healing Summit and any other products that the nonprofit puts out. It also helps us fund and continue our free resources like the Lichen Sclerosus podcast and the virtual support meetups that we do every other Saturday from 2 to 4 and 7 to 9 Eastern Time. If you'd like to join our community or become a recurring member and sponsor this support for someone who may not be able to afford it, please get more information at lssupportnetwork.org/membership. You can also email me at kathy@lssupport.net. Without further ado, let's get into this week's conversation with Dr. Rubin.
This information is for educational purposes and does not constitute medical advice. Speak to your medical professional before making any changes to your care.
Welcome, Dr. Rubin.
I'm so thrilled to be here. Thank you so much for having me. It's an absolute honor.
You are a urologist, but you also specialize in sexual health, and you see a lot of lichen sclerosus patients.
Absolutely. Right? I had a fellowship in sexual medicine, and so I see all genders, and I do a lot of pelvic pain, vestibulodynia, and we do lichen sclerosus. We do all sorts of hormone issues and things like that.
The reason I reached out to you was because I saw a recent paper on the satisfaction of patients with non-surgical lysis of clitoral adhesions. And I was like, yes, this is who I need to talk to because, as we know, clitoral adhesions is one of lichen sclerosus's hallmarks, and it's something that happens to a lot of us. One of the major fears and one of the things that causes anxiety and concerns for a lot of people that I hear is this permanent? Will I ever get back to what I was, or is there something that can be done? I'm excited to talk to you and find out about that. So first off, for my listener who doesn't know, what is clitoral adhesions?
Yeah, and I have a great blog post on our website that talks about the paper, that links to the paper and sort of explains it with pictures and easy to understand information. Clitoral adhesions are not just in lichen sclerosus, actually. We did another paper that showed about 23% of all women have some degree of clitoral adhesions. So I always wear sleeves to explain this. So if you think of a clitoris is covered by a hood, right, a prepuce or a hood, just like a foreskin in a guy who is non-circumcised. And so you should be able to pull back the hood so that you can see the whole head of the clitoris. And you should be able to see the rim around the head of the clitoris completely. Now, 23% of the time, it's stuck to some degree. Now, it may be mild where you can see some of the head, but not the whole thing. It may be moderate, where you can see a little sliver of the head, but it's pretty much stuck there. Or in a lot of times with lichen sclerosus, it can be very severe, where you literally cannot get to the clitoris. But if you feel underneath, there's this like healthy, normal clitoris that lives underneath, but it's really challenging to get to. And so what symptoms can be, you can have no symptoms at all and have perfectly great orgasms and great arousal and be totally fine. But and if this really hadn't been looked at before, you can also get muted orgasm, delayed orgasm, no orgasm, or worse, pain, right? So many people get pain. And what happens is there's this really silly word called smegma. And smegma is just oils and skin cells that naturally develop, right? We exfoliate all sorts of tissue from our skin. And so if it's stuck, what happens is these oil and skin cells develop inside but can't get out. And so I don't know about you, if you've ever had sand in your eye, it is a teeny tiny piece of sand, but my God, it hurts so bad. You can't do anything until you get that darn piece of sand out of your eye. And so what our thought is, well, maybe these keratin pearls and the smegma is building up underneath and irritating the crap out of those clitorises. And so you don't want to be touched down there. You don't want to touch it yourself. It feels really icky. And so you go to your doctor and you say, hey, doc, I can't have an orgasm. It feels icky. And they say, and they don't look at your clitoris and they send you to a sex therapist. Well, what in the gosh darn is the sex therapist going to do? They're not going to look at your clitoris either. And so the problem is we don't routinely examine women's clitorises as part of the vulvar exam, which is what Dr. Kraft and I and Dr. Goldstein were yelling and screaming about, because if you don't look, you're going to miss it. And 23% of all women have some level of adhesions. And the old thinking actually is that it's only if you have adhesions, you have lichen. And that's actually not true.
That's what I understood, and that's what I knew. But I did read that paper about there was other reasons for adhesions, and it blew my mind because I was like, oh my God, I've been saying the wrong thing all this time. Because when I first started researching and learning about LS, that was the thing. If it's adhesions, it's lichens. That's really important to know, especially for people who might be spreading awareness about LS or just talking to your family member or anyone, your friends. Now we know that is not 100% of the time.
Definitely not.
Oh, and just FYI, smegma is like one of my favorite words. I don't know.
Kathy, it's a funny story. It is the only thing I remember from my entire sex education in middle school is the word smegma, which of course I became a urologist. Like I had to, but what are the chances? It's just very funny.
You're like, I have to learn more. I love that. So when we look in the research and when we're looking at like the medical websites and things, we see the word phimosis. Is that the same thing as adhesions, or is that a different process?
So this is a very new area of research. And so what I would say is in the urology world for penises, phimosis is any degree where you cannot pull the foreskin back completely and see the corona of the head of the penis, the rim around the head of a penis that makes it look like a mushroom. That's called a corona or a crown. Phimosis is any degree where you cannot pull the foreskin all the way back. So essentially, if we take the same definition for women, then phimosis should be any degree where you cannot pull the prepuce or the hood back. And so, I think you could very easily say that clitoral adhesions and phimosis are completely the same thing. There's just different degrees of it, right? You may have mild adhesions or very severe adhesions. And so I think for a lot of people, when they hear the word phimosis, they think of it as like a complete phimosis, meaning where there is like total closure. And so I think we're all talking about the same things. It's just a pretty new topic. And so not everyone is always like totally saying the same thing, because even mild adhesions are often missed because doctors don't routinely do it. And so they're going to miss a mild adhesion. I often, when I do my procedure where we do the lysis, I wear magnifying glasses because it is such a small area that it is very difficult to see it unless you have magnification.
To clarify also, when the clitoral hood closes over the clitoris, and let's say it doesn't adhere to the clitoris, but it just adheres to itself and kind of like Dr. Kraft calls it like a zipper on a hoodie or like when you draw the strings together on the hood of a hoodie and it closes over. Is that that's also adhesions and phimosis? Okay. All right. So now that we have that clarified, when you go into doing the examination and you are looking at it with your magnifying glass, which I love, by the way, you are actually pulling the hood back, right? Okay. Because that's one thing we had a really deep conversation about in our membership is that so many doctors won't even touch the clitoris. They're like so afraid of it. Even like when we go for our LS checkups, nobody is really touching, pulling the hood back. And so one of our tips is tell them, ask them, can you please look at my clitoris? Can you please pull it back? Can you just, do your job?
You know what? And this is why we have so much work to do. We have so much work to do because no one taught your doctor how to examine a clitoris. No one. They never learned. And so they feel like weirdos, even the gynecologist, right? They never learned. And so if they feel like it's not their space and it's not their place and they feel weird of what am I looking for? No one ever taught me how to do this. Especially can you imagine a male doctor who's going to go there, like their butts are going to get sued so fast if they're, working in an area that's private parts, right? And so we, especially in this Me Too world that we live in, which is again horrible because now you have a part of the body that nobody examines and that nobody takes responsibility for. So when you have a clitoris problem, and listen, the lichen sclerosus community knows this better than who do you go see? Do you go to the dermatologist? Do you go to the gynecologist? Do you go to the urologist? The answer is you go to whoever actually knows anything about the topic because because there are so many things to know in medicine. And then when you get these issues, you got to find someone who actually invests their time and research and actually really understands these issues.
Yes, absolutely. All right. So let's dive into what can be done, right? So we'll take an extreme case. We have severe adhesions. We can no longer see the clitoris. Can that be corrected with non-surgical lysis?
Yeah, so it absolutely can. And we've had some pretty severe cases that we've been able to open up. Now, if it's very severe, sometimes you do need to go to the operating room if we can't numb you correctly. If we can't do it in the office, then yeah, a surgical procedure is always a good way to go. And sometimes for my very severe phimotic patients, I will recommend we do it in the operating room. But we've gotten used to and really good at doing an office-based procedure. Now, we can probably do more in the operating room and be more aggressive, but I have a lot of patients who don't want to have anything major done and actually prefer to be really gentle and go slow with it and kind of take our time. I have a really lovely patient, actually a lichen patient. This is a hilarious story. She actually was seeing a colleague of mine and I was brought into the room to get a second opinion on something. And I said to her, I was like, I think we can do better here, actually. And she was very hesitant to kind of working together. And ultimately, we really helped her in many ways, but she comes to my office every 6 months for a stretch. She has pretty bad phimosis and we stretch it every 6 months and we get pretty good results with just stretching it, but it comes back a little bit. And so every 6 months she comes back and I say, every time I tell her we can go to the operating room and really open this up. And she says, no. This is like me going to the dentist. I come, I get it stretched. I know I'm going to have to come back, but in these 6 months, I'm going to have the best orgasms and the best sex in my life. And I don't feel like I'm doing anything too aggressive or that could damage any tissue. And I literally love it. I am here for it. And so it is not a one size fits all. We have to look at your tissue. The other really important piece is if it is lichen, is that you have to treat the lichen sclerosus optimally before you ever have a procedure, because otherwise it's just going to scar right away. And so it's really a multimodal therapy.
That is really important. And I'm glad you said that because even when we're looking at surgical lysis, I know one of the requirements is that you have to be in remission. You have to be treating and the fusing and the resorption has to have halted. So let's back up just one more second. And I think I skipped a step. What's the difference between non-surgical lysis and surgical lysis?
The only difference, so really, is if you go into the operating room, right? That's a little bit more of a surgery. And the old way of doing it was what's called a dorsal slit, where you take it and you cut the hood. You make a little slit in the hood and you sew it over to stretch it open. And there's nothing wrong with having a dorsal slit. It's just a little bit more invasive, right? You're cutting the hood, you're stretching it open, and the hood serves a very important role. It protects the head of the clitoris. And so you don't want to necessarily get rid of it completely. And there's a lot of nerves that live in the hood of the clitoris. And so you always want to make sure that you're not damaging. I always fear, right? I always want to do no harm. And so if it's very serious and the non-surgical, meaning the stretching procedure, is appropriate for you, then yeah, let's go conservative before we go, a super aggressive. Does that make sense?
Yeah. So non-surgical, there's no blades or anything, even if it's not in the operating room?
I don't cut anything. I don't sew anything. All I'm doing is stretching. So if here's the clitoris, I'm stretching. I'm using a very fine, sharp instrument to stretch, but I'm not cutting anything. And then we can pull it all the way back. And so it's a stretching maneuver as opposed to any kind of cutting.
Okay. That is great to know. You said there is a sharp instrument that you're using, but it's not a blade. So
it's not a blade. It's sort of like a sharp dissector that it just kind of works at the tissue and really gets in between the folds to get the seam to open up, almost like a seam ripper. If anyone who's sewed anything, which I haven't, I've only sewn people, but kind of like a seam ripper.
I get it. All right, let's take an example. If let's say there's a patient who comes in, she has severe phimosis, and she is a candidate for non-surgical lysis. You've explained how you do it, but what is she looking at as far as like how often she has to come in and aftercare, all of that?
Absolutely. And this is where we're still learning a lot. And so before we had this paper that showed how people do with it, which I'll talk about the results, which were really exciting. Before that, all we knew that it happens in 23% of people. But I didn't have any data to show, well, does actually opening it up work? And what that was so exciting to me, because we published this paper that said, holy crap, we have like 76% of people reported improvement in pain. 71% of people reported improvement in satisfaction with sex. 63% said they improved their sexual arousal. Holy crap, guys. 64% said it improved their ability to achieve orgasm. And this is where I legitimately spit out my drink. So I had a group of medical students, this incredible group of medical students, do all of this data for me. So I'm going to give a big shout out to Monica Myers, Jen Romanello, and Elsa Nico, who did this work. They really did an amazing job with it. And they told me this data and I spit my drink out. 6 women in this study who had this procedure, who had never had an orgasm before, were able to orgasm after this procedure. 6
Woohoo!
like that. And nobody got worse.
Wow.
Nobody lost their ability to orgasm. There were no major complications. And that to me was like a home run. I just it was amazing. And so that's what's super exciting about the procedure. Now, what we don't know, right? Once you do a research, you have 27 million more questions, right? So there's still things that we don't know. We're still trying to figure out who needs repeat procedures. How do we prevent it from coming back? What is the perfect treatment to put on? And I don't think it's a one size fits all. So if you're a lichen patient, then yeah, you need clobetasol on that area. And you also, and we can talk about this later, but like everyone needs hormones, I think, in lichen, like to keep the tissue strong and healthy. I'm a big believer in vaginal hormones for every lichen patient, which we can talk about. But you're going to put something topically, and it's going to be both topical, but also your own manual retraction of this tissue. Men with foreskins pull back their foreskins when they're in the shower and clean the smegma. Otherwise, they get phimosis. And so I think it's the same thing. And so we have to retract. We have to have some degree of separating it ourselves and then cleaning underneath. Does that not? And I don't mean cleaning with any soaps or anything like that, but just kind of just separating, maybe taking a washcloth with water.
That is super interesting. You're the first doctor that I've spoken to that actually said, we need to be retracting that. We need to be
It's never
doing
been
that.
said. The answer is we don't know. We tell all boys past puberty to pull their darn foreskins back. We teach them this. Their pediatricians, their mothers, their fathers, every boy with a foreskin is taught to pull it back. we have foreskins, we have hoods. Why don't we say the same? Is it different? And this data is showing that it's actually not different. We just don't care about clitorises because they don't penetrate or pee through them. And so no one gives a damn about them. But people, 72% of 75 decrease in pain. Like, that's wild.
That is, and with no like surgery, which is insane, because that, like, for a long time, until I saw your paper, I thought surgery was the only way to fix phimosis. Now, I will say, I think I was a unicorn in that I had complete phimosis. My clitoral hood was completely shut over my clitoris. And after like a year and a half of using steroids and following Dr. Kraft and Dr. Goldstein's procedure of soaking and rubbing it in really good, I did start to have separation. And then I started pelvic floor physical therapy, and she would do the manipulation in my treatments. And after about 6 months, I have no adhesions.
And you know what? You're not a unicorn. And the reason I say that, Kathy, is because when a boy with phimosis, let's take a 12-year-old boy who has phimosis, and he goes to the pediatrician. Well, he doesn't go straight to get a circumcision. He gets beta-methazone steroid cream. It's just like clobetasol. He gets beta-methazone steroid cream, and he's told two things. He's told to pull and stretch, apply the beta-methazone and stretch some more, and spend some time working the cream in to stretch the tissue. This is standard treatment for phimosis in boys and men as first-line therapy. When it doesn't work, then you go to surgical management. And so I'm not doing anything that novel or amazing. I'm taking what everyone knows about penises, and I'm just saying, why can't we apply it to the clitoris as well?
Yes.
And all of a sudden, everybody's like paying attention.
Yes, I love it. I want to add that while I was applying, so I use halobetasol ointment, which is a little bit more of a lotiony kind of texture. And so I actually would masturbate when I would apply my steroid. So I think that, along with the steroid, would just helped. And it
to your point, right? When you would have arousal, right? So when you have a prepubertal boy with foreskin, you don't pull it back because it's going to hurt them, and it's going to stick right back together. You wait for puberty. And what happens in puberty? You get a surge of testosterone, which is oily skin, which breaks up the adhesions. And you get erections, which literally like stretch out and break up the adhesions there. And so for you were able to break up those adhesions both from the inside by stretching, by arousing your clitoris to grow it, as well as from the outside by stretching it that way. So your body instinctively knew exactly what to do your own lysis of adhesion. The problem is most people barely know where their clitoris is because you got to do gymnastics, you got to get mirrors out, you got to get magnifying glasses out. It's not, penises have a little bit more like largeness to them. And so there's more surface area to work with. And so it can be very challenging to do this at home, but you prove that it can be done, and it should be done that way.
Wow. Thank you. So walk us through step by step.
So once we decide, and again, maximal lichen therapy, I cannot see active lichen going on. So we have to make sure you're using your vaginal hormones, you're using your steroids, you're in remission, from the active lichen state. And then you come into our office and we put a very strong topical numbing and we let it sit for quite a while. And I'm not interested in torturing my patients. If we feel pain, we stop and we put more numbing on. Sometimes we inject a little numbing if we have to, although rarely do I have to. And we literally just then stretch with a tool to stretch open the tissue. It takes about 30 to 40 minutes, depending on how aggressively scarred down. Again, my very severe lichen patients are a little bit more challenging. And sometimes the architecture is just really hard to get through. And you're not going to necessarily get a perfect stretching thing. But again, remember that patient, it wasn't perfect, but every 6 months, she has wild results with just even a partial sort of lysis procedure, which just fuels me to get more data to do this. And so once we're done, we give you a mirror. We often take pictures because we believe it's better than a home reveal to see the before and after. It's just so exciting to see the before and after pictures, especially because you guys don't look at these every day. We do. And so it's sometimes really helpful to see where you started and then where it goes to. And then we give you a mirror and we show you how to pull it back, what to do, what to put on there. So for a lichen patient, I would definitely put whatever steroid you're using on there, pull it back once a day. And then that's it. And then we talk to you after to see, what did you think? Do you think it helped? Do you think it was worth your time? Was it good? And that's what the data we collected was basically asking patients, what did you think? And we got some just incredible responses. I'll read a few of them here that we put in the paper. Patient said, I had no idea about the clitoris before meeting Dr. Rubin, and I believe this needs to change so women are able to better understand their body. The procedure gave me more sexual confidence and freedom, as well as a greater understanding of my genital anatomy. It's critical that women are educated to ask for this examination and for physicians to educate their patients about it. It was painless, so easy to recover, and an absolute game changer for me. I was extremely grateful to receive this. So again, we just asked people, what did this do for you? What did you, think of this procedure? And so, what's cool about it is it's really sparking other people to start looking. I have a wonderful colleague who I didn't know, who saw me speak at a conference right before the pandemic. He's a urogynecologist in Chile, and he's doing a whole trial to say, oh my God, he said, he keeps messaging me on WhatsApp saying, these are everywhere. Like, what's happening? There's a pandemic of adhesions. I said, well, you never looked before. Kudos to him for being open-minded to open his eyes and say, oh my gosh, I see this now. And he's actually looking to see if he sees improvements in bladder symptoms after lysing these procedures. And he has some preliminary data, which is quite exciting. And so there's a lot happening in this space. Well, not a lot happening. We want more to happen in this space, but at least something is getting started.
I love that. So the aftercare is basically continue stretching this on your own, using your steroid. And so you talk about hormones. Let's dive into that a little bit more, because hormones is something that I'm really curious about, but haven't been able to find a lot of information or an expert when it comes specifically to LS. And I know you said you have thoughts.
So I have a lot of thoughts on this. And I think LS treatment should always be two-pronged. It should be steroids and hormones. The reason is LS happens in hypoestrogenic states typically. So you see LS pop up, like my niece when she was 8, developed LS. Postmenopause, women develop LS. Yes, there's a lot of peri and premenopausal people who are breastfeeding develop signs of LS, right? So it's often in a very hypo or low estrogen state. And so there is a hormonal component to this problem. Now, that's not to say hormones will cure LS, but what hormones do, local vaginal hormones, what they do is they strengthen tissue, they heal it, they make it strong, they acidify it to have healthy bacteria, and they create an environment where the tissue is very healthy, it lubricates better. And so the LS it responds better to treatment. And remember, steroids thin everything out, which while it's good for thinning out the thickened lichen, it's bad for thinning out the healthy tissue. So that's why vaginal hormones are really important to beef up the tissue so that it doesn't all thin out from the steroid. And again, I speak about this a lot on my social media, on Twitter, on Instagram, Dr. Rachel Rubin, because the vaginal hormone therapy is safe for just about everyone. There is literally no patient on earth who is totally contraindicated, who I would ever say you cannot use this. Now, there's an occasional patient with active breast cancer who she and I are going to have a conversation with her oncologist, but I still think there is no data to show risk and the benefits outweigh the risk. And so vaginal hormones are very easy to do. They're local. They literally prevent urinary tract infections. They keep the tissue very healthy. Vaginal estrogen is what's commonly used. There is some data to show that some androgens would be helpful. So vaginal DHEA, or I know Dr. Kraft and Goldstein, the estrogen testosterone combinations are extremely helpful to the tissue and work quite well. And so I think that that one of the biggest mistakes people make in lichen therapy treatment is that they're not on a hormone as well to keep the tissue strong and healthy. Now, premenopausal women, that's controversial, but the thing is they don't hurt anyone. Vaginal hormones don't hurt anyone. They don't change your menstrual cycle. They don't hurt your partner. They don't go in your bloodstream. So they don't cause any problems. And so the question really is, well, why not? Why not put it in there? Why not try it and see if it helps? And so it's definitely an area that needs to be studied at length. But in my opinion, is very underused in this space.
Interesting.
And let me just say, actually, I saw a patient just this week who said to me she had untreated lichen sclerosus, and she's panicked and she has horrible pain and all of these things. And she says, well, I've been using clobetasol on and off for years. She doesn't use it consistently. Mm-hmm. She had on her medication list, she had estrogen inserts, and she's menopausal. I said, oh, do you use this? She said, no, I don't want cancer. And I said, oh my gosh, here we are. Vaginal hormones have never, there's not even a case report that you can show me that show any risk of cancer. But you know what does cause cancer? Lichen sclerosus.
Lichen sclerosus, yes.
Right? And when I told her that, and I was like, if you're not using your steroids regularly, like you are at real risk, a not zero risk of vulvar cancers, as all of you know. And I was like, you literally have a risk of cancer that you are ignoring. And if you use the vaginal hormones, you have zero risk of cancer. So like, that's how crazy the feelings are around this, but there's no data to go to prove it.
Yeah. Yeah. Unfortunately, there's a lot of fear, right? There's fear of the steroids. There's fear of the hormones. I hear it a lot as well. I tell all of my people who come to me, if they're menopausal, are you using estrogen? Are you on a topical hormone? Because I listen to you. I listen to
peri and postmenopausal. Absolutely. Peri and postmenopausal is a must. Yeah. The premenopause, that's where we need more data, right? Okay. And I would love to see that data. So I can't say it's a must, but I have an inkling that it would help, right? But that's me being a scientist and wanting to study it in more depth.
I love it. Okay. So we've come in, we've had the one session. How do you tell someone, okay, you don't need to come back, or you tell someone, yeah, you need another treatment?
Mostly it's patient driven at this point. And so it's very much your body, your choice. These are not life and death operations or procedures or anything like that. I have patients who really drive the show here. And patients now, after this paper came out, oh my gosh, people are emailing me from all over the world and saying, holy crap, Rubin, I have this. My doctor won't do anything about it. They don't know what to do. Can I come in? And that's why we have to train more people and teach more people and get more data. And so, listen, patients are finding it. They're finding me. They're coming to have it done. And I really let patients drive the follow-up in terms of, did this work? Can we do better? I would say our repeat lysis rate is pretty low. I have that one patient who's here every 6 months, but I wouldn't say that's common. You know, I think we're really trying to learn who benefits at all, right? If you get it done and you don't notice any difference, why would I do it again? Or why would we, right? Why, if you have clitoral pain and you have very bad adhesions and we relieve the adhesions, but your clitoral pain is still there, well, we have to look for other sources of the clitoral pain. And so that's really important. But I've had patients who come find me because they see an article I've written or something like that. And they say, I have an adhesion. It's right here. I always remember this one patient. She found me from like it was either Reddit or, a Refinery 29 article. And she shows up at my door. She says, I have an adhesion. It's on the left side and I need you to get rid of it. And I put my magnifying glasses on and I'm looking and I was like, this is so small. Like this adhesion is so mild. There is no way this is causing like what you're describing. She said, Rubin, do the adhesion. I said, okay, let's do it. I separated out this tiny adhesion and she was the happiest customer. It all got better. She was so happy and she did fabulous. And so again, her body, her choice, yes. I really do listen to patients and saying, okay, and the answer is we don't know everything. So we do our best. The data shows me that I'm not causing major harm. Will I hurt someone one day? Of course, right? Like risks are always possible. We talk through risks and benefits, but we see so much benefit with very little risk that's what's really, really exciting.
I love how patient focused it is, right? Because I know a lot of the times when we go into the doctor, we feel like they're just trying to get us out of there and they're just throwing a medication at us and showing us out the door. And with the way that you're practicing, it's we are the center. Everything is, you're listening to us. How are we feeling? What do we want to do next? And you're educating us. These are your options. And we're a team.
I love that. And we're very goal oriented. Like I could say the lichen is the problem, but you could think, well, my orgasm is the problem. Like Rubin, I can't orgasm. And so I need to hear that and listen to that and say, okay, here's our plan to improve your orgasm, because your orgasm is really important. And it's really quality of life really matters. And we don't often give that messaging through. I had a colleague say this, I thought it was really good, is you're the CEO of your body, right? You're building your team, you're building your C-suite. And so I come in as a consultant, or maybe I'm I'm your CMO or something like that, your chief medical officer, and I'm helping you design, what your perfect team looks like. But at the end of the day, you're the boss. You could fire me. You should fire me if I'm not doing a good job. You can bring in new team members, and you got to rotate them sometimes. And I just love that analogy, because it gives such autonomy to your body that you are the boss of it, and you get to decide what ultimately you do. And if you're going to pay payroll, like make sure people on your payroll are worth it, right? And so I could go on that analogy as a new business owner. I could go on that analogy all day long.
Oh my God!
By the way, all of my staff deserve payroll. They are incredible. They are so wonderful to patients.
I love that. I love it so much. Are there exercises that we should be doing maybe before we were able to see a doctor?
I love the Kathy method. When we got called the Kathy method, I think it's fabulous and wonderful. And we could write it up, because it matters. So get your mirrors out. Start looking. The first step is look, right? Look and see what your own body parts look like, and play around to really poke and prod and see, look at my article. We have a lot of pictures on the article, the blog on our website, rachelrubinmd.com, and compare yours to the different pictures. Say, oh, these look moderate. Oh, these look severe. Show your partner if you have a partner, get them to look. I had a woman, we did a clitoral lysis yesterday. Her partner, fiance, was in the room and was fascinated, was standing right behind me watching, and was just, loving every second of it. He said, how did I never know it was this bad? How did I not know that it didn't look like that? Why didn't we pick this up? She said, I can't believe I've had this for so long. It was a magical, transformative experience for the couple, because they really understood the anatomy. They understood what they were doing and why they were doing it. And so I had another lady I saw this week where she had an adhesion, and I asked her, she came in for follow-up for everything. I said, oh, and the adhesion, she said, oh, I took care of it. I stretched it out myself. It popped right open. It's totally fine. It didn't fix my pain that I have X, Y, and Z, but the adhesion is gone. And so absolutely get down there, get your mirrors out, start looking, start talking about it, asking the questions, and that would be incredible, a place to start.
After the procedure, you actually show us how to do the manipulations.
Yeah, I think that the manipulations, honestly, sometimes people just don't get close enough to stretch it. Anytime you want to find your clitoris, if you have labia minora, the inner wings, which some people with lichen do not have, but if you have labia minora, you follow them up and you get to the hood of the clitoris. Okay, so this patient has a clitoris here, right? It's a big, huge thing, but the hood covers it. And so what I see a lot of people doing is they pull up from up here, or they pull like this. But what you got to do is you got to get really close to that hood and pop it out so that you can see the head. You got to pop it. And so you got to get really close right next to it and pop it out. And it should look just like the head of a penis. Now, this is just a little like an incorrect diagram, because it doesn't have the details of it, but it looks just like the head of a penis. And if you cannot see something that looks like a tiny head of a penis, you have adhesions.
Afterwards, we're still using our steroids, no change, or do you have to use it more often?
If you're on maintenance therapy at that point, I probably have you at least put it on the clitoris every day for a little while, just to let it heal, and then probably go into some maintenance therapy, but then, pulling it back at least every day. You can always put Aquaphor or Vaseline on the area. We played around with that. We played around with hormone creams. We're still trying to figure out what the right amount of pulling it back, what the right amount of maintenance is. And just because the adhesion comes back doesn't mean your symptoms come back. And that's the really important thing is adhesions. If you have adhesions, but you're not bothered by them, if you have great orgasms and great quality of life and you're enjoying, you are not broken. Like just, it's okay. Like we have no data to say you have to have these adhesions removed. And so it's really if you're bothered by it, if it hurts you, if you feel it's affecting your sexual health, like that's when you come in and say, hey, I want to see if this would help me. And it helps a lot of people, but it doesn't help everybody, right? I can't say that it helps absolutely everyone.
Right. Nothing's 100%. Do you recommend pelvic floor physical therapy to kind of help continue with that manipulation?
You're never, you're never wrong to have a physical therapist on board. They're the greatest people.
Answer.
They're the greatest people on earth. And you can always learn how to be better with a pelvic floor physical therapist. Do I think you need a pelvic floor physical therapist to help you pull back the clitoral hood? No, but my patients often have other issues, pelvic floor dysfunction, all these things. And so it's always the right answer. And so you're never wrong to have them on your team. And they're the greatest people on earth.
Yes. We always say if you have an LS diagnosis, you need a pelvic floor physical therapist on your team. Even if you're not using them right away, you need to have them. So when you're ready, you already know who you're going to call. I love it. Do you do this procedure for cosmetic reasons? So let's say they don't have any issues with sex. They're not having keratin pearls. It's just an emotional kind of mental thing that I can no longer retract my clitoral hood and I want to be able to do that so that I can feel whole.
Yeah, absolutely. Of course.
Okay. Because I know a lot of doctors don't do it for cosmetic reasons. Can we go into a little bit more depth of what is the surgical lysis of adhesions? And then what are some of the reasons you wouldn't do it?
Surgery, typically, again, a dorsal slit procedure. Now, you can do a lysis procedure where you just stretch in the operating room and you could just be more aggressive because the person's asleep, they're not having pain. So you can do a little bit more. I've done that before where you do just the stretching procedure, or you can have what's called a dorsal slit surgery where you cut the hood and that way you can pull the head of the clitoris out a little bit. And so that you have a suture, you do often need a suture in that tissue, which is normally fine and people do very well with it. But certainly when you're cutting things, you can risk injury to different body parts and there are always potentials. But the data is very good on the surgical procedure. It's just that surgery is you got to go get surgery, you got to go to sleep, you got to get anesthesia, right? It's a whole to do. And I think for your point is women often do say, oh, I don't want to go under anesthesia to deal with my clitoris. No one's ever cared about my clitoris before. They're going to think it's weird that it's not. You care about your clitoris. Men care about their penises. You should care about your clitoris. It's not weird, but it's often difficult to get a patient into the operating room for that procedure, which is why it's nice that now we can say we have an office-based procedure that is sort of like, very good for most patients and can work quite well.
It's also difficult to make sure you have the doctor that's knowledgeable, that's done this repeatedly, because you don't want to go to someone who doesn't know the anatomy correctly, who isn't proficient in this procedure, and then they make that wrong cut. And now you have more issues than when you started.
Absolutely.
So, yeah,
we're working on training people. ISWSH, so isswsh.org is a great website to find a provider, to find someone who is knowledgeable about clitoral adhesions. That doesn't mean they know how to do the procedure, but it means they should be knowledgeable about it. We're working very hard at teaching courses.
Is there any scenario where you would say, no, I'm not going to perform this on you?
Well, if you don't have any adhesions at all, there's not much to do. That would be like a good reason. If there are adhesions, right? If there are actual adhesions and a patient is bothered by them, and bothered means whatever the patient wants it, right? Bother is a subjective thing. And the answer is we have data now to show that multiple things get better. I had 6 women orgasm who never orgasmed before. I love that data, right? And so that's data that I can really go to and say, hey, we didn't know what this did, but when we did it and we asked these women, this is what we found. And so absolutely, I think it's everything. It's a discussion. And that's why I love my job, because people come in and I really get to know them. Actually, the first visit I do with people is virtual. And I did that because of the pandemic and because I cannot talk to you for an hour like this. I can't do it. Right. And so everyone says, well, the problem is with my clitoris. You have to look at my clitoris. Like, I'm not coming to do a virtual visit and see you. And they're always grateful they did the virtual visit, because in the virtual visit, I get to know them, their history, their world, and figure out what it is they care about, what it is they want, what their medical story is. And that way, when they come in for the procedure, right, where I don't like to meet you on the first date and stretch things on the first date, right? I want you to know, like, and trust me. I want you to know that I know you and I know what you care about. And then I get a sense of, okay, what we can do. And so I think it's really important not to just treat the adhesion, but we may find that you have low libido that could be treated medically. We may find that you have orgasmic dysfunction that there are other ways to treat. And if I don't ask those questions, then I'm just treating an adhesion, which may not be the only problem. And so I do things a little bit differently. I'm going to ask you questions about your surgical history. I'm going to ask you questions about how you were raised thinking about sex. I'm going to ask you questions about your bowels and your birth control use. And I want to find out about that stuff, because sometimes you come for me for one problem and then I'm like, I can do better here. Like, we can do a little better here. Like, trust me. So we'll do the adhesions, but maybe we should also talk about your UTIs. Maybe we should also talk about your libido.
Because a lot of the times we don't think it's connected.
Right.
But you as a specialist, hey, there's something else that could be going on here too. Let's look into that.
And then we can help build your team, right? So we can say, this physical therapist is the person you need to see, or this, mental health person is the most amazing person ever. You should do this, right? And if I don't get to know you, I can't give you good advice.
Yeah. Thank you so much. This has been amazing. If somebody wants to reach out to you, work with you, what's your website for them?
Absolutely. RachelRubinMD.com. You can please sign up for our newsletter. I would love for you to sign up for the newsletter. We have a YouTube channel, Dr. Rachel Rubin, which we're putting all these cool videos on, and we're going to do more. So subscribe to our YouTube channel. I'm very loud on Twitter and Instagram. It's Dr. Rachel Rubin. I'm really hoping for 10,000 followers on Instagram, which I think Dr. Kraft has 30 million. So I'm very far behind her, but that's my newest goal. And just thank you all. What a wonderful community you guys have built. And the world will only change with patient advocates getting angry, rising up. And thank you for all that you do. It is just, I can't say enough how important it is. I know you all know, but just thank you. Thank you.
Thank you. Wow. That was an amazing conversation. I learned so much. The possibilities of being able to open up the fusing of the clitoral hood without having surgery, and it really maybe only needing one session, that's amazing. Like Dr. Rubin said, this is a fairly new procedure. It's being taught. So you may not be able to find a specialist in your area that is doing this, but just know they are out there and they are growing. Dr. Rubin and Dr. Kraft are teaching this to specialists, to gynecologists, to dermatologists, to urologists, so that more specialists can help people all over the world. This is not just in the United States. There are options. There are things that are coming. So definitely reach out to Dr. Rubin if you're in the area or you want to make an appointment with her. I will have all of those links in the show notes. No worries, I got you. If you found this episode helpful, please share it with your community and tell a friend. I hope you have an amazing week, and I will talk to you next time. Bye.